Good evening, everybody, and welcome to this year's Royal Society of Biology West Midlands branch Charter Lecture, celebrating the Royal Charter that the then Institute of Biology received in 1979, and the West Midlands has enjoyed an annual Charter Lecture since. We have a very pertinent topic this year, and really one of the most suitably qualified people to talk about it as well. So the speaker will be presenting a fairly short summary, after which we'll have a question and answer session. So please feel free to enter your questions into the chat at any time, and you can do that whilst the talk's going on. But have in mind that if you ask a question during the presentation, the speaker may yet cover that topic. I'm the only one that'll be able to see the questions, and I'll be putting them to the speaker on your behalf. And the author of the questions will remain anonymous. So I'm really very pleased to welcome Professor Graham Medley, Director of the Centre for the Mathematical Modelling of Infectious Diseases at the London School of Hygiene and Tropical Medicine. As many of you will also be aware, Graham is a current member of the Scientific Advisory Group of Experts, providing scientific advice to the UK government on the novel coronavirus SARS-CoV-2 causing COVID-19, as well as chairing the Scientific Pandemic Influenza Group on Modelling. Graham also had the misfortune of being my PhD supervisor, which started 10 years ago this week, Graham, but also fortunately ended 6.5 years ago. It does mean I can tell you from experience that we have, a really excellent scientist as speaker this evening. I should have moved these slides on, my apologies. Right, here we go. So Graham, thank you again, thank you very much, and it's over to you.
Thank you very much, Dan. There'll be a short hiatus whilst I share my screen, and I'll look for confirmation that you can see it.
Yeah, we're okay, Graham.
Yep, good. Thank you very much indeed. So thank you very much. It's a great honour to be invited to present this lecture, and I will do my best. Times are rather short at the moment, though, so please do bear with me if these slides aren't as polished as they might have been. I will go through the slides I've got. I will sort of talk, but then, and that will not take 1.5 hours. And then I'm more than prepared to answer all the questions that I can, because I think that's probably going to, rather than me guessing what it is you want to hear, it's probably better to actually for you to tell me what you want to hear. So I'm going to essentially run through 6 or 7 things. I'm going to focus almost entirely in the United Kingdom, because that's what I know about. I'm going to just give an idea about how in the UK science feeds into policy, so the structure of it. Talk about something about modelling for policy. So my background is, I sort of trained as an ecologist and ended up working on the interaction between pathogens and their hosts, so viruses, bacteria, some work on helminths infections as well. And so virtually all of that modelling has been academic research, and the modelling for policy is slightly different. It's very different, and I'll talk a little bit about why, and what the role of modelling is in developing policy advice. And I'm then going to talk a little bit about the model structures, but don't worry, I won't have any equations. I'll do it in a way that's hopefully intelligible, so you can see what we're missing in terms of the models. I'll give a specific example of where a model did actually change policy. And then finally, at the end, talk a little bit about where we are in the United Kingdom and where we might be going. And if there are questions about elsewhere in the world, then I can do my best to answer them, but it's not my area of expertise. So this is how the UK science advice looks from my perspective. So in 2017, I was invited to chair this group which does pandemic preparedness. So for the first 3 years of that, we were doing modelling in order to answer specific government questions, but all entirely within the Department of Health. Then in January, February of this year, when it was clear that we were most likely going to have an epidemic of this novel coronavirus, SPI-M becomes a subgroup of SAGE. So SAGE starts to convene, and we change to SPI-MO. So SPI-M is a collection of academic modelers, and we say in between pandemics, we work to ensure preparedness or try and improve preparedness. And then when the actual epidemic starts, we are doing modeling in real time or near real time to try and provide advice. So it's a group of independent academics, and places that they come from are represented there. And we try very hard to come to a consensus. That's my job, is to take that consensus to SAGE. So I attend SAGE as the chair of SPI-M. And SAGE has a number of other subgroups. So SPI-B, who are kind of psychologists and behavioral experts, nerve tags, who are virologists and clinicians, and the hospital onset group, primarily infection control people. And then there are another other groups that are evolved around. So RAMP is something set up by the Royal Society to provide some extra capacity for research, and the Royal Statistical Society as well. And they all have some kind of a voice in terms of SAGE. And what SAGE is supposed to do is to synthesize the evidence into advice. So my job is very much to take the evidence to SAGE. So in terms of the way that it's supposed to work, is that SPI-MO is essentially public. I mean, it could be public. We don't do anything in terms of policy. What we do is in terms of understanding the science and compiling the evidence. SAGE is an advisory committee and turns that evidence into actual advice. And then that goes on up through the chains, through the officials, the civil service, and they are the ones who ultimately advise the ministers on decisions that need to be taken. So it's supposed to work in quite a formulaic way, and by and large it does. But in a crisis, in an emergency, all sorts of shortcuts appear. So I've gone from here direct to COBRA officials and had meetings with them, although I've never actually met ministers. And the idea is, of course, the ministers are taking, and decision makers are taking advice from many different people in many different sectors. And kind of one of the privileges of making decisions or sitting in that seat is that they can decide which advice they take to inform their decisions. So I'm going to give you a perspective from here, but very much kind of looking down. I'm going to talk about the evidence. I'm not going to disappoint you, because I'm not going to go in any detail about the biology of the coronavirus. I'm not going to go into any particular detail about the current situation in terms of where we are. I'll say something about it in general. This is much more of a kind of an overview. We take 3 steps back from the situation and try and look at it to understand it from that perspective. So, as many of you will be aware, modeling becomes very important in a pandemic. And the reason it's important is because of the uncertainty, because nobody in February knew what was going to happen. Then we have no data to rely on, and so modeling steps in to fill that void. So it's important because of the fact that people are having to make decisions. We know something is going to happen, so people have to prepare for it, but we don't know what it is. And so modeling fills that void in the lack of data. But of course, without data, modeling is essentially impossible. So we're in that very difficult position whereby we're trying to model things that we don't really know that much about. We know a lot more now, but at the time, we really knew very little. So modeling sits then in this position whereby the modelers are seen to have the power in terms of being able to direct policy, and lots of discussion about various papers and reports that were written at the time to try and support government decisions. But really that's a kind of a situation because of the whole environment at that time. Modeling takes on this unusual perspective. In normal times, models really sit between data and policy. So data themselves tell you exactly what's going to happen. It's the collection, interpretation, and analysis of data is really what science is about. That has to be turned into, in this situation, into advice, so that people who are making policy can do so with evidence in front of them. And models really sit between those two, turning data into advice. And of course, a model can be as simple as a linear regression. Actually takes data and turns it into something which might be more suitable for supporting decisions. So we kind of take a position in SPI-M as a group that we don't look back at all to evaluate past. So you can ask me about situations in the past and we can discuss them, but that's not something that we specifically model. However, we rely very much on data. Data drives what we do, and all data is historic. So we work in the context of what has happened. And then really re-echoing in the first point is that the models need data, but sometimes the data is sufficient. So if we're asked, for example, where people are currently being infected, then we can't really answer that with a model. If what we say is, well, if we had the data, then we would know, and you wouldn't need to model. So really, modeling kind of fills this role of either sort of providing the data that doesn't exist, or else translating data into understanding, which can be support policy. The models that we use from, I'm not going to go into technical details, but they're relatively simple in terms of structure. So they are SEIR type models. So we divide the population up into people who are susceptible, people who've been exposed but are yet infectious, people who are infectious, and then people who have recovered. We are now beginning to enter the point in time when we have to worry about immunity. So immunity up to now we have considered, I think with the best evidence, as being solid. So very few reports of people being infected more than once. But if immunity does start to wane, then it's likely to do so on a timescale that means that people potentially can become reinfected again. And we are just going through a whole system of looking at all the uncertainties that we know about. What do we know and what don't we know? The things that we do include in models, and which really is what makes modeling interesting, is heterogeneities. That is differences between people. So the basic model assumes that everyone is the same, but pathogens are very good at finding differences, finding variation, either in terms of biological state. So for coronaviruses, this coronavirus, age is clearly a very important heterogeneity. A model that doesn't include age is not really going to be very useful. Heterogeneities in terms of behavior, so that we know that contact rates are important, and some people have more contacts than others and are more likely to get infected. And so those heterogeneities are important. And also access to healthcare. So as I'll talk about, one of the main drivers for terms of controlling transmission is contact tracing. And that is not unique or sort of equally accessed by all people. So all diseases all human diseases end up essentially in what people call hard to reach populations or dim corners of society. So people who are less generally involved in healthcare, and again we see that happening with this disease as well. And then another major issue that we have in terms of the models, certainly at the beginning, but not so much now, is the fact that nowhere in any textbook will you find the severe kind of non-pharmaceutical interventions, or NPIs, that have been used almost globally in this pandemic. So I did a search on my computer last week to look for the word lockdown, and it appears on my computer on around the 13th of March. So 10 days before what we call lockdown actually happens. I don't like the word lockdown because it doesn't actually mean anything, and different countries had different states that they call lockdown. So I'll try not to use it. But clearly that level of NPIs, those non-pharmaceutical interventions that were put in place, as I say, have no precedent. So they weren't included in any model that we had before the pandemic started. So we do know that those core groups are always important in any epidemic. So the core groups are the people who are most likely to be infected and most likely to infect. So identifying those core groups is critical to understanding how any epidemic is going to proceed. So for something like measles, mumps, rubella, and even influenza, it's school children are normally the core group. So they are people who have very high mixing rates, more likely to be infected, and because they are mixing and contacting lots of other people, they're more likely to transmit to them. I think it's pretty clear now that school children are not a core group for this coronavirus. Whether biologically or for other reasons, the virus does not seem to explode within that group, as by explode I mean transmit as easily as it does in young adults. So young adults, if you have to choose an age, are probably a core group, but then we are also having core groups such as healthcare workers earlier on in the epidemic. The core groups change through any epidemic. So the first kind of start of the epidemic, so back in March in the United Kingdom, we would have had some people or some groups would have been core. And so this reproduction number, the rate at which the virus increases, is always highest at the start of any kind of epidemic or any epidemic wave. They're the first people to become infected, and potentially they're the first people to become immune. However, because the core groups change during any epidemic, that unfortunately that is not, or doesn't appear to be, sufficient in terms of being able to control the infection at the moment. So at the moment we're seeing different core groups in different places around the country at different times, and that's likely to continue for as long as the epidemic continues. The main heterogeneity that we have to grapple with in terms of modeling is the kind of network structure that our behavior creates. So at the moment, certainly in the United Kingdom and in most countries, although some countries have implemented policies to change households, there is no appetite politically to change household structure. So when we introduced those strong NPIs in March and we all went home, all went home. And so the households really are the core for what goes on in terms of transmission. And the thing that makes that important is the fact that households connect the rest of society. So I've included kind of the three main other layers that we have, and that is schools. So children go to school and they come from different households, and all the children at the end of the day from one school, most of them go back to different households. And similarly for work, you know, that people leave their houses, they go to work, mix with other people at the work, and those people all go home to different houses. So households act as a kind of conduit of contact between schools and work. And then the other main thing that we do, if we're not at school, we're not at work, and we're not at home, is that we socialize. So So we go to gyms, we go out to bars and restaurants, we go and get our hair cut, we meet with friends and family. So that's another major arena of how people connect together. And then we have up here, top right, something which at least initially was something of enormous concern. I hope that measures have been put in place that they are no longer of the highest concern. And that is those institutions whereby, hospitals, social care, so care homes and prisons, for example, are all areas where you have enclosed populations, so kind of cruise ship situations, if you like, where there's obviously potential for large outbreaks. So that's the kind of basic structure that we're dealing with in terms of the virus being transmitted. And therefore, it's the basic structure that we're dealing with in terms of policies. How do we stop this virus being transmitted? Well, we have to address this network because this is the route whereby transmission occurs. And that's not an easy problem because almost by definition, most of these things are there for connections, to provide connections, particularly the social aspects, the social environment, so the gyms, the bars, and the personal care. To a large extent, they are there to provide social interaction. So the whole point of bars is that when you go, there are other people there. And so that really makes it a challenge. If you want to control the virus through controlling contact, then it makes the hospitality sector a real challenge in terms of control, because the whole point of them is that you go to meet people. Just as a specific example, this is two pictures here of the networks created in England by children going to school. So each of the blobs is a school, and then you see the lines coming out of those blobs, and those are where a school is connected to another school by the fact that two children go to each school and they live in the same household. And what you can see is that these networks, so on the left is primary education and on the right is secondary education. These networks alone are enough to connect the whole of the country. So the virus can quite easily go from down in Cornwall to up in Northumbria, just by going from child to school to home to school to home and so on. And that's both for primary and for secondary. And so when you add on top of that work, the fact that the people living in households are also going to work as well as the children going to school, and you add on top of that family and social circumstances. So personally, in the past few months, the only long distance travel I've done is to go and see family. When I say long distance, I mean up the M6. Then you can see that those networks very quickly become very complicated and very hard to manage and very hard to understand. So it took a long while for the Department of Education to get this data together. So this is published in a preprint at the moment by James Munday and colleagues. So we do have mathematical models that include network structures, but what we don't really have, and actually it turns out there isn't much theory for, is dynamic networks, so networks that change. So we understand how disease spreads through static networks that don't change, but modeling on dynamic networks turns out to be a little bit of an area that's underexplored. So lots and lots of research activity in that area in the coming years, I'm sure. So we disrupted the networks. That was the whole point of the NPIs that we put in place, was to break those networks down, to stop the linkages. And so the question is how we put them back together without allowing a return to exponential growth. What we would like to be able to do is to go back to full economic activity, full social activity, and disconnect that from the virus transmission. But we haven't achieved that yet. Nowhere's achieved that. It's a challenge. The other big dimension in terms of understanding or modeling is the fact that no matter what you think might happen, people will do something completely different. So how they actually get rewired and how policy feeds into behavior, again, is an area of great concern and a lot of thought and a lot of research. So, for example, there's been quite a lot of talk of the fact recently that United Kingdom has said that pubs and bars must close at 10 p.m. And the thing is that you don't know what impact that will have in terms of these networks. You know, there really is a kind of a gap in terms of policy of being able to know what policies enacted will actually be how they will turn out in terms of what people actually do. We have to worry a lot about geography as well. So we're starting to see, we have seen really since June that there is large variation developing in terms of prevalence of infection in different places. And in terms of different kind of social geography, so different contacts, and that's not surprisingly because we contact people in different ways. In our social networks are very different from each other, and the virus is exploiting those in different ways. When I first gave, or a few months ago when I talked about this, I had to talk about stochasticity quite a lot because the prevalence was quite low. That's not going to worry us for a few months yet, I don't think. We're dealing with large numbers, so chance isn't having much of an effect. So modeling for policy is a challenge because the models aren't perfect. And we have to emphasize the uncertainty. It's important when collecting evidence and offering evidence for policy decisions that everybody understands what we know and what we don't know. So that's an important challenge for us, because an important paradox actually in modeling for policy, because of course what the policymakers would love to hear is that we know something and we know how things work. But of course, what we want them to know is that we don't. So we focus on given questions to a large extent. So this is questions that we are asked by policymakers, so by the COBRA officials, essentially saying to us, you know, what should we do about this? Or if we closed schools, what would happen? What would be the impact of closing schools? That was the first question we were asked. And so we attempt to answer that question as quickly as possible. And frequently that is only a matter of days, you know, probably more like hours than days. Nothing more frustrating than being asked a question, be working on it to produce an answer, and then the policy decision is made before you've got the answer. That is frustrating, but it has happened, and inevitably it will happen because the decision makers are the ones in charge. They're making the decisions. It turns out that most of my work at the moment is essentially as a translator. So how can we turn a policy question, which is often quite a reasonable policy question, into something that can be modeled? So a specific example is we have been asked, yep, can we open garden centres? And that's a perfectly reasonable question, sort of back in May and June. But how do we answer that question? It's not something that we can specifically model because we don't have garden centres in our models. And even if you did open garden centres, would anybody go? Well, everybody might go, you know, if it's the only thing that's open. So predicting the impact of that is really very difficult. So it's one of those instances where we have to really say, we don't know. Very hard to predict, but we can give you potentially some guidance. We can say, well, from experience, we know that if you tell us how many people went to garden centres last year, then potentially, and how old they were, then potentially we can say what impact that might have. But then it turns out that nobody knows how many people went to garden centres last year or how old they were. And then when we get questions that we can model, situations where we can model, we have to translate numbers and graphs and output into policy relevant information. So this is the basis, of course, of science communication, but with a particular purpose, that whereby you want to make sure that the advisors and the decision makers do actually understand what the models are saying. And that is not easy. I mean, it sounds very, very easy to say, but we really are kind of grappling in terms of translation all the time. We have to worry about time periods, and that's something which turns out to be quite a difference between modelers and policymakers, that when we're making a model and running a model, we want to know how long, or we have to know how long to run the model for. Policymakers, certainly in a crisis, are less concerned about that. So coming back to that question of what would be the impact of closing schools, the first question that we would ask as modelers, well, how long for? And that's an open-ended question that the policymakers didn't really want to answer. So you know, they're looking to know what the impact of closing schools is, rather than over a time period. And that's been something which is, I think, in all epidemics is an issue. And as I said earlier, sometimes once you've got the data, you don't need the models. The data always wins. This is a specific example of where modeling really has influenced policy. So it was realized sort of back in February, March, that in order to control this virus, you know, the level of NPIs that we put in place is not sustainable, and that we need other mechanisms to control the virus. In the absence of a vaccine, the obvious one is contact tracing. We know quite a lot about contact tracing. It's used for sexually transmitted infections all the time. But most of that contact tracing is forward. So in this diagram here on the left, you see that you know, we have a primary case who infects 4 people in the next generation, and they go on to infect some people. And forward contact tracing is where you identify an index case, and then you look to see who they've contacted, and you identify those people as being potentially infected and quarantine them, or let them know that they've potentially been exposed. And so most contact tracing is forwards. It turns out for this coronavirus that actually transmission is highly clustered. So some people transmit to lots of others, and most people transmit to very few. So these kind of super spreading events, as they're called, or clustered transmission, is a feature of this virus. And it's a combination probably of 2 things. One is that some people are just very infectious and shed a lot of virus. And secondly, that they've got to be in a position whereby they're in an environment where the virus survives, and there are lots of people there with them. So what that means then, that an infection is far more likely to be in a cluster than to create a cluster. So if you do backward tracing, so you look not just for the case, but the primary case, so you identify the same index case in this generation, but you try and identify the primary case, so who infected them, then that means potentially you identify members of a cluster. So backwards contact tracing, I think, is now pretty much universally done around the world, but certainly the modeling that we did, or modeling that was done by SPI-M, was quite informative and quite good evidence for policy in this country. So now backwards contact tracing is the kind of de facto in the United Kingdom because of this clustering effect. Okay, so question, where are we? So we're in a situation now where we're essentially in the early stages of the epidemic that we would have had we done nothing. So had this virus caused no disease, then we would have had an epidemic that would have probably infected somewhere between 60 and 80% of us. and over a period that would have, the peak would have been around June, July. So the epidemic would by and large be over by now. However, we stopped that epidemic on the 23rd of March in the United Kingdom. We introduced these strong NPIs, which reduced the reproduction number below 1. So the reproduction number is a kind of a measure, a basic measure of the virus's ability to transmit in the current circumstances. And if it's bigger than 1, it means that each case on average generates one other case, or more than one other case. If the reproduction number is less than 1, then the virus is not going to survive, it's going to decrease. If the reproduction number is bigger 1, it's going to increase, and increase exponentially. In other words, there'll be a constant doubling time, and the rate of increase increases as the numbers increase. So we're part way through an epidemic that we have controlled. The prevalence got down to really quite low numbers in the middle of the summer, but now is climbing. So we're up to a situation where today we've got about getting on for 500,000 people infected, and about 40,000 infections per day. And of the order of 10% of people have serological evidence that they have been exposed. So we are not halfway through the epidemic yet. We're still in a stage, and we're really in this kind of flip-flop situation where we're either having the reproduction number bigger than 1, so prevalence is going up, or we're having the reproduction number less than 1 and the prevalence is going down. And we've seen so far 1 up, 1 down, and 1 up. The incidence and prevalence are never going to be flat. If they look flat, then they're in the process of changing. Yeah. So during the summer, when the prevalence didn't look flat, it was changing from being negative to positive growth rate. So this reproduction number is essentially made up of two components, if you like. One is the product between a contact rate, so the numbers of people that I contact on every day, the probability that when I contact those people, transmission gets passed from me to them, and then how long I'm going to be infectious. So in terms of interventions, we really only have 2 at the moment. The first is this contact reduction. So either we try and stop people meeting as much. So you say to me, right, don't go to the pub, don't go to work, don't go out. So I'm not contacting people. Or you say, okay, well, if you do go out, wear a mask, wash your hands, keep 2 meters away from people. Yeah, try and reduce the probability of transmission when I make contact with people. Now, that can either be targeted or not. So in the 23rd of March, basically we applied it to everybody, so it's not at all targeted. We are now applying it at different levels locally, so at different regions. And the idea of contact tracing is that you targeted individuals. So you find those individuals who are most likely to be infected or at a higher risk and say, right, you self-isolate, don't go out, reduce your contact rates to 0. So we've got those interventions, and then the other interventions we have essentially to reduce the infectious period. So in this, what you want people to do is to stay away from other people if they are infectious. And it's kind of been lost a little bit in the messaging in the United Kingdom that actually that's a kind of a linchpin of what we must do, is to try and get people to stay away, to self-isolate if they have symptoms, even if they can't get a test. Now, if you can get a test, all the better, but actually it's the symptom reduction of transmission, I think, is something which is pretty essential. So of course that has the effect of reducing the infectious period. Now we know that contact tracing is not actually going to be sufficient to control this virus, because the people are infectious before the onset of symptoms, and some people are infectious without ever developing symptoms, or symptoms that are so mild they don't recognize them. And so that this on its own is not going to be sufficient. So reducing this duration of infectiousness, so having people spend some of their infectious period away from others, is probably not going to be enough to control the virus. We're going to always have to do some of this other contact reduction and reduction in the probability of transmission. So where are we going? Well, we're in this process now of trying to figure out essentially which of the individual measures that we did during that period of lockdown worked. Very hard to pick up the epidemiological evidence for each intervention, and even harder to pick up the economic impact of each individual intervention. We have some idea about schools, but that's partly because we have had influenza pandemics in the past. And as I said, school children are one of the core groups for influenza. So we knew about that. We have relatively little epidemiological evidence for other modes of contact. Between household contact is something that comes up again and again in contact tracing. Hospitality, as I've said, has been implicated in many different places as being something that's a risk. But these risks change. So even if you think it's a risk now, it might not be in the future. But something like personal care covers everything from nails to hair to property and so on. So actually unpicking and trying to figure out which activities are going to be responsible for most transmission is not straightforward. We know that all the NPIs together reduced this reproduction number from about 3 to about 1/2, and that currently we are at about 1.5. So what we are doing at the moment on average in the United Kingdom is effectively we've halved transmission rates, but that means we are still growing exponentially. And the other key thing to remember, and that I don't focus on it because I am advising in terms of the epidemiology, the epidemic transmission, but none of these interventions is free. They all impose harms, and considerable harms in many cases, on freedoms, on social economic interactions, on the economics. There are no easy solutions. There's nothing that we can do to control the virus that won't impose those harms. And similarly, if we don't impose those harms, then we are going to continue having the epidemic that we managed to avoid in the summer. Just to give you some idea about what that sort of looks like, this is some work done by Nick Davies and co-workers, published in Lancet Public Health. And so this was actually done quite early in the epidemic, when we were looking, when it was suggested that we might have this lockdown to prevent a large epidemic. Is then, of course, there's a modeling question. Well, you want to know what the triggers are. So one potential trigger, and probably the one that has stuck in terms of thinking about of why we want to control this virus, is the National Health Service capacity. So the people who are sick with coronavirus need hospital attention. If everybody who could get sick with the virus got sick at the same time, so if we had an unmitigated epidemic, then the hospitals would overflow to the point at which not everybody who needed to go to hospital would be able to go to hospital. And that's just coronavirus patients. And that would be exceeded by several, well, an order of magnitude, or maybe even 2 orders of magnitude. And that's something which I think that is kind of fairly fixed in most people's minds about something they want to avoid. So one trigger could be when you get to a certain number of people in hospital. So when you reach a certain number of people in hospital, then you trigger and say, right, at that point, we're going to try and lock down and reduce transmission. I'm going to focus in on one of these. So this is the 5,000 bed trigger. So when you get to the hospital full with 5,000 beds, so these gray bars here are different levels of triggering of different levels of NPIs. Of course, with the uncertainty, it means we can't then say exactly when there would be a trigger, but actually you can see in this model that there's quite a clear consensus that would occur at some time around now. We're getting to the point where we'll end up with 5,000 people in hospital. And so if you want to avoid overflowing, and just think what overflowing from the NHS means in reality, if you want to avoid the NHS overflowing, then you need to reduce the reproduction number to below 1. Yeah, that brings then transmission down. You then have a period of time where people go back to work, they go back to normal activities, and we end up going back to having to lock down again at some point in the future. So that's the kind of one of the patterns that we're in. We're having to have the epidemic, or we are having the epidemic, but over time rather all in one go. You know, that's one potential option. Another option would be just to have it, you know, and say, well, you know, we've got to have the epidemic, let's just get it over with. The other general option would be to say, well, we're not having it at all, let's eliminate the infection. And there are, of course, examples of that in different countries. So Sweden is cited as an example of having the epidemic, even though they have actually reduced quite a lot of imposition in terms of reducing transmission. Whereas New Zealand, for example, has gone with an elimination structure, elimination policy strategy. So that decision about what you do is clearly not a scientific decision. It's a decision that has to be made by essentially the population. What is it that we want to do? You know, how long can we go on with these severe NPIs in place? Do we want to continue to do that? You know, are we prepared to have too many deaths that not everyone can die in hospital? All those kind of questions is really not something that science can answer. They are social preferences, and the decision makers, the politicians we elect, have to make those decisions. And so we try as far as we can on SPI-AM to be policy neutral and to ask, well, what is it that you want to achieve? If you do this, then what's the consequence? We're not advising in terms of strategy, although of course as people we might have individual preferences about the way that we would do it if we were in charge. So we're going to be living with this for some months. We're either going to be in a situation where we reduce the reproduction number to less than 1, in which case then we are going to go back to having small sub-epidemics in different places, which will result in local impositions, but more national freedom. If we allow reproduction number to be bigger than 1, then at some point we're going to have to go to some kind of stronger imposition of NPIs, of non-pharmaceutical interventions, if we don't want the numbers of cases to continue. Ultimately, the end is undefined. We hope for a vaccine. Of course, there will be all sorts of problems in terms of supply, how many vaccines we have, and delivery of those vaccines, and how you negotiate the transition from no vaccine to relying on vaccines. However, my first pandemic experience was with HIV back in the 80s. And essentially, we were promised a vaccine in 5 years' time every year, and that's continued. So I personally I'd love to have a vaccine, but I don't think we can necessarily rely on it. If we don't have a vaccine, then this process will continue essentially until most people have been exposed to the virus. And at that point, although we don't know whether there is solid immunity to infection, and probably isn't solid immunity, the whole point of our immune response is that it improves our chances of surviving the second time we're exposed to a pathogen. And so we eventually get to a point whereby there is enough exposure to the virus that it ceases to become an epidemic problem. It's still a health problem, but it's not an epidemic problem. And a few years ago, rather presciently, I wrote something about this called "When an Emerging Disease Becomes Endemic," about this transition from the epidemic state to the endemic state. So you can go and read what I thought 2 years ago about the process that we're living through at the moment. And that's all. So thank you very much for listening. I'm very happy to take any questions. I direct this Centre for Mathematical Modelling for Infectious Diseases. So those are the details there. You can find my email and you can email me, but you and everybody else will be emailing me. I can't guarantee, I apologize, to actually answer the emails. I shall stop sharing there if I can find the right button.
Thank you very, very much. We have had a few questions. Give me a moment and organise my screen.
Whilst you're doing that, let me just say a few words about the question. So I find myself in this difficult position whereby I'm providing scientific advice to government to help them make decisions. And I think as any advisor, advisee relationship, there has to be some kind of trust and some kind of discretion between the two. On the other hand, I am a scientist, and public understanding of science is important to me, and explaining what I think is going on is important as well. And that position puts me in a slightly difficult position. I know that this is going to be this is being recorded and will be made public later, and there may well be members of the press on the call. But just bear in mind that when I'm trying to answer the questions that I'm, as has happened in the past, I don't want to end up on the front page of a national newspaper. But I will do my best to be as open as honest as I can.
Thank you, Graham. So to all the those in the meeting, if you do have questions, please feel free to put them in the chat, and I shall go ahead and ask Graham those that we've already had. So Graham, why have school networks across the UK only been influenced? Sorry, why have school networks across the UK only been identified recently and not during other epidemics?
So they were identified. So James Munday, who did that research, he did his PhD looking at influenza transmission in the Netherlands, and so he managed to get hold of, from the Dutch government, that information that allows him to draw those networks. And he did it primarily because of measles. So the Netherlands has large outbreaks of measles periodically because a proportion of people refuse or don't wish to be vaccinated. And so he did it on the basis of that. Governments, not surprisingly, are quite reluctant to share data if they don't really see that they have to. He tried to get the same data from the UK government, and the UK government declined to share that data. However, in March, they suddenly thought it might be a good idea to have the same kind of understanding for the UK. So I think it's been understood that those kind of networks are important, and we knew from the Dutch work that James had done that it was important, but we just didn't have that data for the UK until recently.
Thank you. Was there something specific in the modelling that influenced the change in policy for wearing face coverings?
No, so that is a very good example of a situation where if you don't have the data, you can't model it, and once you have the data, you don't need to. So we can include in the models some kind of small percentage and say, well, let's suppose it reduces transmission by 10%. But those numbers are just made up and really have no effect on or no kind of policy level impact. You don't change policy, I don't think, on the basis of a speculation in a model. because we can speculate in models easily and a lot. So it's a situation where it's really the data which are going to drive that. It's the data are mixed, but the other reason for making policy to remember is to change behavior, and that is not necessarily directly correlated with the policy change. So I think by asking people to wear masks, and in some cases requiring people to wear masks, it's essentially a way by which you cannot forget that we are in the middle of an epidemic. Their impact in terms of transmission, I think, is still an open question.
Thank you. Okay. Next question. I have heard recently in the news that people can be exposed to the coronavirus for a second time. Is that true?
So there have been, I think, about 11 case reports of people who appear to have a second infection. So they've had one documented infection from which they have recovered, and then have had a second. And in some cases, although the virus is the same, it's got a slightly different genetic signature. So it is a second infection. Any virus that happens, the question is whether that's anecdotal at the moment. They will be unusual cases at the moment because they have to be sick enough the second time to be recognized. So there won't be random observation. There are some very good large-scale studies that have been set up, one in the United Kingdom called the Siren Study, which has enrolled people working in healthcare, and is specifically designed to be able to find reinfections. So I think again, it's an area of huge uncertainty. I think we are expecting it to happen. What those second infections look like, we don't know. However, past experience suggests that second infections are almost invariably more mild than the primary infection.
Thank you. I hope the audience don't mind. I have a follow-up sub-question generated by the end of your answer. Do you think that's, even though it's genetically different and therefore identified as a new infection, do you think that milder infection is due to some partial immunity?
Yes, it will be due to some kind of partial immunity, most likely. Yeah, that when people are infected, they develop either antibodies or T cells or both, which have some impact on the next infection.
Thank you. Right, next question from the audience. Much appreciate Professor Medley's presentation, very interesting. Is SPI-M modelling the impact of a non-sterilising / partially effective vaccine?
Yeah, we are. Nobody, I think, expects the first vaccines to be perfect. And so, yeah, that's something that we're not directly involved in. There's another group called JCVI, Joint Committee for Vaccination and Immunisation, that makes immunisation decisions, and this vaccine will go through that committee. But it's something that clearly we're keeping a very close eye on.
Thank you. Next, in a large-scale pandemic like this with so many environmental factors, how do you, and I think there's a typo here, so I'm gonna make an assumption here. How do you tell correlation from causation, or infer in terms of what is driving spreading events?
Yeah, very, very difficult and spot on. You can't really. I think one of the things. So, let's talk about scientists wanting to be in charge. If I was in charge, then we would be having a load of different experiments. Yeah, I would be closing pubs in one place and opening them 24/7 in another, and that would tell me very quickly whether or not the role that pubs are playing. I'd be doing all sorts of experimental things because I am a scientist, and so I would be teasing out that correlation from the causation. Teasing out the causation from the correlation, but clearly that's not the way that you would like, or potentially not the way you'd like politicians to work, but to play those kind of games with people's lives. So yeah, it's a very good, and that's by and large, or a large area where our uncertainty comes from. So yeah, good question.
Yes. Why are certain areas of the UK more affected than others?
Again, very good question. I think that we always knew that London would be ahead because of the density and contact rates are slightly higher in London, and the demography is slightly different. I don't think then we knew what was going to happen, and certainly in terms of the kind of the situation we're in now, I don't think we could have predicted precisely what happened. Although, having said that, if you take the map for coronavirus prevalence now and put it next to the map for the 1918 influenza pandemic, and put it next to the map for tuberculosis at the end of the 19th century, then they are clearly very closely correlated. And whilst that may not be causation, there is certainly something in, I think, the situation whereby essentially social deprivation. So I talked about households. So the more people living in smaller houses is going to be conducive to transmission. People who work at home or can work at home are obviously going to be to a certain extent better off than people who are having to go out to work. And again, that's a marker potentially of social deprivation. Yeah, so pathogens in general are very good at picking out inequalities. And this virus is doing exactly that. And this virus is exacerbating them. And it's making people whose lives are more difficult, even more difficult. So I think it's quite clear from the ONS data, the surveys that have been generated, that essentially it's deprivation, and I mean not just deprivation, but it's the consequences of deprivation. So compliance with self-isolation, for example, the biggest predictor of whether somebody is going to self-isolate is the amount of resources that they have in terms of, say, financial savings, and so that's a impact. Thank you.
Thank you. What would you say is the most important next step in being better prepared for future situations like this?
Yeah, I mean, I'm tempted to say something glib, but I won't. So to say the first pandemic I was involved in was HIV, a chronic virus, sexually transmitted, very different to coronavirus. We've had influenza pandemics since, and other coronavirus outbreaks. I think what we can probably say for sure is that the next pandemic will be unexpected. I think that the thing to put in place are the kind of structures for how you deal with the unexpected better. Yeah.
Has there been any modelling of changes in resistance to antibacterial or antiviral sprays as a result of increase in the use of those things like hand sanitizer?
Oh, no, very good, very good. I've seen the question asked before, so I imagine that somebody has jumped on that opportunity, but I don't know of it actually occurring.
We have what is your opinion on colleges and universities being opened?
So I think this is one of those questions where I'm going to try very hard not to give an opinion. Quite on the other hand, I will. I mean, it's quite clear that it was decided relatively, early on that in terms of policy decisions, that education is important. That stopping generations, cohorts of children and young people getting an education or delaying it is just kind of unacceptable in a way. And so the population at large seem to have agreed with that decision. And so then you've got to proceed and carry on with that education. In terms of how it's actually done, kind of operational decisions about where students are whilst they're being educated, I think is a different issue. But decisions have been made. So I'm sorry if that's an unsatisfactory answer, but
do the models take into account the virus forming new strands, or is that not such a major factor with COVID?
So people are very interested, and there is a whole industry, and it is pretty much an industry in the United Kingdom, of sequencing viruses and trying to relate viruses to different outcomes. So clinical outcomes and transmission outcomes. No evidence as yet is conclusive. All viruses vary genetically, but actually associating a change with a change in biology, with a change in phenotype, connecting genotype to phenotype is very difficult. If it's clear and it happens, then I'm sure we'll spot it. But as yet, nothing has been seen.
Thank you. What is the scientific evidence for not social distancing within year group bubbles in sixth forms being relatively safe? I understand there is, of course, always a transmission risk.
Yeah, so it's about these networks. It's about the fact that you try and reduce the number of contacts that people make to prevent transmission. The point about bubbles, though, about having groups who only meet together, adds an extra advantage, which is that if you do have to ask people to self-isolate, it's only that bubble, not the whole institution. And it means potentially in terms of testing that you can focus on particular situations. So there are two answers to that question. One is that you just try and reduce the number of people that number of people that everyone talks to and contacts. And then if you do get an outbreak, that self-isolation could be much more targeted rather than to the whole organization. And that kind of bubbling approach, that drawing lines around different groups, is clearly something which is going to be common. It happens in all institutions. It's going to happen more and more, I think, in terms of the way in which we try and structure those contact networks to avoid major outbreaks.
Thank you. Next question. Over the pandemic, and this relates to a previous answer that you've given, but over the pandemic, has the virus mutated?
Yes, it has. They always do, but there's no evidence that mutation, those genetic mutations, have translated into a change in phenotype.
And a question on along similar lines: if coronavirus is able to mutate, will it ever be possible for us to gain control over it?
Okay, so I'm not quite sure what you mean by gain control, but we have loads and loads of viruses that we transmit to each other. Many of those, well, 5 of them are coronaviruses. And essentially coronaviruses, the endemic coronaviruses, get transmitted between young children. So most people are in their first year of life when they're first exposed. The disease caused by those coronaviruses is essentially a snotty nose. And anyone who's had closely with 1-year-olds and 2-year-olds knows that. That is a frequent symptom of respiratory infections in children. So we don't know what happens when somebody in their 80s, in old age, is exposed to one of those coronaviruses for the first time. So we don't know that the endemic coronaviruses that we have wouldn't cause disease in older people if they were exposed for the first time. But of course we don't know that this coronavirus is going to be the same as those. I think that given the challenge of eradicating this virus is probably insurmountable. Maybe we'll be lucky and the first vaccine will be perfect. But I think that is something which is kind of decades away. It's taken us, almost 30 years to get polio to the level we've got it to. And so eradicating a virus from the whole globe is not something that's easily undertaken. So we are going to have to learn to live with it, I think.
Thank you. Really interesting thoughts on existing coronaviruses, actually. What are the highest priority medical interventions being developed for COVID-19? And there's a second part to that question. Are the anti-malaria drugs hydroxychloroquine and chloroquine safe and effective treatment for COVID-19?
The last two are certainly safe, but I think the evidence is that they have no effect whatsoever. We're in a dangerous position. I mean, this virus is nasty. And so there are plenty of people who will tell you that they have a treatment for it. However, careful clinical trials are the only way of being able to distinguish things that work from things that don't work. And a number of different interventions are going through trials now. I personally have more faith or more hope for treatments than I do for vaccines, because we have a lot of drugs and a lot of them are being trialed in many different places. And added to that, you add on the kind of clinical experience. So and I'm now told by clinical colleagues that when somebody is admitted to hospital and is ill from coronavirus, they don't need to do a diagnostic test. They can just tell from the sound of breathing that this is COVID. And so they're learning very quickly how to help patients. And we are learning which drugs work and which drugs don't. So I think the situation is that survival is going to improve enormously.
The next question is somewhat policy related, but what does the R value have to get to before another lockdown is initiated? And what is the probability of this happening before the end of the year?
So the reproduction number measures the slope, how fast it's going up. The prevalence of infection tells you how high it is. So it's those two pieces of information, how fast it's going up and how high it is, which give you some indication of how much trouble you're in. So I think I said on the radio about a week ago, we are, one of the big problems with this virus is the fact that it's taking 3 weeks between infection and death. That means that the death rates for the next 3 weeks are already determined. And we are going to get up to 100, easily over 100 deaths a day in the next 3 weeks is a kind of consensus opinion, but my personal view as well. At what point will decision makers make a decision about what they're going to do? That's really up to them. My job is to kind of tell them where we're going. And then if they come to me and say, right, we're thinking of doing this, I can potentially inform them about the effect of that intervention. I think that if at the moment the reproduction number is about 1.5, I think that if we don't reduce it, then we will be in a position whereby we have overflow of the NHS well before Christmas, well before the end of the year, that's the situation we're in. At what point decision makers decide to intervene is entirely up to them, and they will have many different reasons for doing it.
Thank you. Has any modelling been done regarding why there is a small population of people who suffer long-term after contracting coronavirus, such as neurological symptoms and fatigue, etc.?
Yeah, no, so long COVID, as it's been called, clearly it's a clinical problem, not something that really we can model at all. But I know that clinically, my colleague researchers are all over it and trying to understand it, trying to understand the patterns of it, what interventions are there any drugs that work to cure it, and so on. So yeah, it is recognized as a very big problem.
does Professor Medley think that the desire to reach consensus and speak with one voice, first within SPI-M and then through SAGE, resulted in the scientific advice being diluted in the early stages of the epidemic?
No, because what we're trying to do is to reach a consensus of the things we know, but that doesn't, of course, stop us either describing the things we don't know, or indeed describing the dissension, where we're disagreeing. So I think that at all stages of the epidemic, not just the early stages, I don't think that there was any indication to me that any advice was ever diluted in order to find something that everyone could agree with. That's not what consensus means. Consensus in this case means that we agree what the evidence tells us, and where we disagree, we make that clear. Yeah, and where normally what the disagreement is about, some people saying, "Oh, we know this," and somebody else says, "No, we don't." Yeah, that's the kind of disagreement that we end up with, and that is then communicated to decision makers.
Is there any evidence that a more unified strategy covering the whole country would have made any greater impact compared to currently the different regions, Scotland, England, etc., all having slightly different approaches?
So viruses, I'm going to kind of answer this generically, but pathogens and viruses are very good at exploiting heterogeneities, as I said. And clearly, if heterogeneities are created by different institutions, different kind of governments and jurisdictions, then you're going to end up with variation that virus is going to exploit. So it's not just the fact that nations within the United Kingdom aren't necessarily coordinated. It's the fact that nations within Europe aren't coordinated. In fact, the whole world isn't coordinated. So we are seeing variation in terms of countries throughout Europe. That, of course, then creates a challenge in terms of travel and people becoming infected in one place and moving to another place with the virus. There's been no suggestion that we wouldn't have freedom of movement within the United Kingdom. And so that does mean then that there has to be some kind of uniformity. And that any variation of that uniformity is obviously going to be driven by different jurisdictions taking different views of the evidence, and making different decisions. Has it made things worse? I don't think I would say personally, and this is obviously not something that SPI-M would look at. As I said, we look forward rather than backwards. Don't think there's any evidence that I know of to suggest that there's been a huge material difference by different measures in different places, other than the fact that Scotland and Wales at least kept their lockdown situation going longer, and so ended up with a lower prevalence when they did remove them than England did. That's the only difference, I think.
Early on in the pandemic, do you think the UK government relied too much on modelling that used historic data rather than observing and adapting to the situation in real time?
No, so the models that we had, obviously we can't model something that we don't know what's going to happen. So we have to, the model structures we use have to be pre-existing, but we adapt them in real time to information as it comes out. I don't think that, so the answer is no, essentially, that question.
What is your opinion about the quality of the data that is being published in this country and worldwide on the number of cases and deaths?
Again, very good question. Epidemiology is fraught, for any disease, is fraught with difficulty in terms of measurement. I mean, let's take deaths, for example. Now, it's pretty clear that you know when somebody has died, but it's often unclear what they died of. And so you need to have some kind of definition about what is a COVID death. So at the moment, the definition that is, we have two different data streams. We have the kind of public health data stream, and they are using the definition of anyone who died within 28 days of a positive test. And of course, that will include people who died of something else but happened to be positive. And it will exclude people who died of COVID 29 days after their test. It's not going to be perfect, but you do need some cutoff. The other data stream we have is death certificates where clinicians write on the cause of death, primary and secondary causes of death. So we have two ways in which we can capture deaths. That I think means that the death data, at least in the United Kingdom, is good in the sense that it's there. It's not always presented. We deal with date of death, whereas the death numbers that are given out, I think, in most days on the media, on the television, are deaths by date of report. So it's not when the death happened; it's when the death was notified, and that's different. And so the death data I think is better in this country. I think globally, deaths have always been more difficult to count. Cases, infections, I think is again something which is very hard, because it really depends how hard you look. So what's happened at the moment is that when areas like the northwest of England have got a high prevalence, then loads of tests go there, which means then that your ability to be able to use that data in the southwest of England is reduced because there are far fewer tests. So really the number of cases of infection that you find really depend on how hard you look. And so those data are always at best correlated with what's really happening.
We're nearly out of time, but there happens to be one question left. How similar is COVID-19 actually to SARS?
Well, I'm not a virologist. I think that it has a lot of similarities, and I think that in essence, this virus is a transmissible SARS. So SARS was a coronavirus, more pathogenic than the current coronavirus, but again, liked those close environments, those kind of low ventilation, high transmissibility environments to live in and to transmit. This virus quite likes those as well. This virus is less pathogenic, but it also does very well transmitting in different situations. So if you think of this as a less pathogenic but transmissible SARS, then that's probably the best working model.
Okay, thank you, Graham. Okay, so unfortunately we can't really provide the kind of round of applause that you might expect in an auditorium.
I'm used to that now.
But you have received many thanks in the chat. Thank you to all of the audience for providing their questions. I'm sure you will join me in our appreciation of Graham's presentation and answering all of our questions. Thank you also to from the West Midlands branch of the Royal Society of Biology. We've sent you a charter lecture gift made by a West Midlands company as it's a regional event. So I hope you find good use for that.
Thank you very much. I will.
You're welcome. Thanks to everyone for joining us. I hope you found it useful.